Okay, we're gonna go ahead and get started here in just a minute. I'd like to welcome you all to our event. Just to introduce myself, I'm Dr. John Matheson. I'm a professor in the Philosophy and Religious Studies Department, and I also direct the Florida Blue Center for Ethics here at UNF. And I'd like to welcome you to our first event of Ethics Week. Hopefully all of you know this is our second annual Ethics Week, which is full of events. There's something each day this week, all conversations like this one, where we're discussing interesting, relevant ethical issues that apply to everyone. So there's a schedule of events for this week out in the front. If you didn't take note of it on the way in, make sure you do that on your way out. But today we're going to have our panel discussing, is healthcare a human right? This event is sponsored by the Florida Blue Center for Ethics, as well as the Office of Public Policy Events. And we have three panelists here who are going to be leading our discussion. And after they walk through some initial thoughts on the issue, then we will open it up for a Q&A, and people will have a chance to ask questions, raise their own comments to add to the discussion as well. Okay, so let me introduce our panelists for our discussion today. So right to my right is Dr. Nick Seabrook. He's the professor and chair of the Department of Political Science and Public Administration. He also directs the Office of Public Policy Events, which this is one of the events. And his research examines the intersection of law and politics, and so we'll have a nice angle on our issue today. Next to him, we have Dr. George Rainbolt, who's a professor of philosophy in the Department of Philosophy and Religious Studies. His expertise lies in ethics and social political philosophy, and so we'll be providing a philosophical angle on our issue. And then finally, we have Dr. Elizabeth Paul, who teaches in the Brooks College of Health. She has over 15 years experience in the healthcare and pharmaceutical industry and is a global health advocate. So let's first just welcome all three of our panelists. So I'll turn it over to our panelists, who will start by talking about how each of their individual disciplines has kind of a unique angle on this question and has unique insights to offer. And then I'll turn it over to Dr. Nick Seabrook to lead some of the discussion, and then we'll go to the Q&A. All right, thanks.
All right, well, thank you, Dr. Matheson, and thank you to the Florida Blue Center for Ethics for co-sponsoring tonight's event. Is healthcare a human right? This is a question that is a hot topic of discussion right now, not just here on this stage, but also in Washington, D.C., as we are in the 13th day of a federal government shutdown that is premised in large part over this precise question. Exactly how far should the government go to provide healthcare coverage to its citizens? And this is a long-running debate in American politics. And the story, I think, of how we got to where we are today, where we're 2 weeks and with very little progress in sight in reaching an agreement on reopening the government, this all really goes back to 2010. I know this was a very long time ago for our students in the room, but there was a president back then named Barack Obama, and he passed a piece of legislation called the Affordable Care Act. And the legacy of the Affordable Care Act is what has become a key point of contention between Democrats and Republicans and precipitated the current federal government shutdown. The Affordable Care Act was the first major piece of federal healthcare legislation to pass, really going back all the way to the creation of Medicare and Medicaid in the 1960s. There was an attempt at healthcare reform during the presidency of Bill Clinton. Ultimately, however, that attempt was unsuccessful. But healthcare reform was a major issue during the 2008 election, both in the Democratic primary between Barack Obama and Hillary Clinton, but also in the general election as well. And it was a key issue that President Obama campaigned on. The Affordable Care Act had a few different components to it. One of them was the individual mandate, a requirement that all Americans purchase health insurance or else pay a penalty on their tax return. The second was an expansion of Medicaid. Medicaid is the federal program that provides health care coverage for low-income Americans. It's jointly administered between the federal government and the states. And what the Affordable Care Act did was to widen the population who were eligible for Medicaid funding and to provide additional money to the states if they opted to sign up for the expanded Medicaid coverage. The third component, and the one that is involved in the present shutdown, was the creation of healthcare exchanges on which individuals could purchase health insurance and receive subsidies from the federal government to help them pay for those policies. And those subsidies would become a key point of contention both during the COVID pandemic and also in the recent debates in Washington, D.C. We did see some changes to that basic framework. The Supreme Court in the NFIB versus Sebelius case struck down some elements of the Medicaid expansion, those that had attempted to make it mandatory. And so instead, states would have the option to participate. During the first Trump administration, the individual mandate component was repealed. And at the same time, more and more states started to sign up for the Medicaid expansion. And so the trend really between 2010 and the present day has been a significant expansion in the number of Americans who receive assistance in obtaining health care coverage from the federal government. During the COVID pandemic, the Biden administration sponsored and Congress passed the American Rescue Plan, which significantly increased the subsidies and widened the pool of eligible Americans that could qualify for Medicare assistance. But a crucial component of that bill is that those subsidies were temporary. They were set to expire. Earlier this year, the Republican Congress passed a bill which made additional cuts to Medicare as part of their tax cut package. And then the expiration of those subsidies prompted Democrats to refuse to cooperate, to refuse to vote to extend financing of the government until Republicans would agree to extend those subsidies. And so this impasse that we find ourselves at in Washington really turns on this question of whether it is an ethical obligation of our government to ensure that all citizens have access to health insurance, to medical care, not just those who are supplied it as a condition of their employment, as a benefit, not just those who can afford to pay for private health insurance, but also those who are unable to do so. And what begins as a philosophical or ethical question eventually becomes a political question. What types of care does the government provide or pay for? Who pays the taxes that are necessary to fund it? Do you have a system of socialized medicine where the government itself directly provides care? Or do you have some kind of public option to subsidize the existing system of private insurance? Federal spending on healthcare in the fiscal year 2024 was around about $1.6 trillion, or about 25% of the entire federal budget. That number is expected to rise to $1.8 trillion by 2035. Across the entire US economy, national health expenditures, so the total amount that's spent on healthcare in the US across all payers, sectors, and levels of government, represents about 20% of our GDP. So 20 cents of every dollar of economic output in the US goes towards healthcare, which consumes 1/5 of the entire American economy. And at the same time, the US national debt right now is $37.6 trillion, 3 times what it was in 2010 when Obamacare was passed. So as a political scientist, The question for me when it comes to the healthcare debate is always one of political trade-offs. It's always one about coalition building, about building support, about convincing the public that it's in the best interest to do one thing or another in healthcare policy. And I'm sure we'll return to some of these debates about political questions and trade-offs during the course of our discussion. But I will now turn it over to my two colleagues on the panel to say a little bit about their perspectives on this question. George.
Hi, I'm glad you're here. So Dr. Seabrook just provided a sort of a on-the-ground, sort of politically, the politics of healthcare. I'm, as a philosopher, sort of going to be focused on the view from 3,000 feet, the sort of the broader issues. And so if you ask the question, if you ask any question of a philosopher, they're going to ask you to define your terms. And so you say, well, is healthcare a human right? Well, what's a human right? Well, obviously, there's human and there's right. So a human right is a kind of right. And so what is it to have a right? What do you have when you have a right? When someone has a right to do something, or a right that someone gives them something, what that means is that some other person or agency owes them something. So my landlord has a right to $1,800 from me every month. I owe them $1,800. They have a right to $1,800. That's distinct from obligations of charity. I think that at my income level, I have an obligation to give to charity, but nobody is owed my charity dollars. Nobody has a right to my charity dollars. So there's a difference between my landlord's right that I give them $1,800 and other people's my obligation to give to charity, which does not have any right associated with. Nobody has a right to my charity dollars. Does that make sense? Okay, so now we know what a right is. Well, what's a human right? A human right, what I just told you is oversimplified but broadly agreed to by almost everybody. Human rights, it gets more complicated, and so I'm going to give you one view, and if you want to, we can, in the question and answer, we can talk because there are alternative views about what a human right is. But the most common view, and actually my view as well, is that a human right is a species of moral rights. It's a kind of moral right. So what is a moral right? Well, rights exist within systems of rules. So let's take a really simple system of rules. Standing in line. There are rules for standing in line, right? You get into the back of the line, not the front of the line, right? And so when you get to the front of the line, then you have a right to, if you're in, I was in Publix yesterday. I was in line at the pharmacy counter, and when I got to the front of the line, I have a right that they serve me and not the people behind me and things like that. So there's a system of those. Those rights aren't in the law. There's no laws about this. It's a convention in our society. In other societies, they have different conventions. So, for example, my son was in India this summer, and he said that the conventions about lining up are very, very different in India than they are in the United States. So there's different conventions about these sorts of things. So some rights are created by conventions. Other rights are created by legal systems. So, for example, not quite yet, but sometime I will have a right to Social Security payments, right? I'll reach a certain age, and I will have a right to Social Security payments, right? And that's a right under the U.S. legal system. So I have a right to a certain amount of dollars from the U.S. government, and that's a legal right. It's a right under the U.S. legal system, right? It's created by, it is part of the U.S. legal system. But most people think that there are rights that are not conventional and they're not part of legal systems. They think that they are rights that are moral rights. So consider the case of Arthurine Lucy Foster. Anybody know who Arthurine Lucy Foster was? Arthurine Lucy Foster was the first woman ever, and she was African American, the first woman and the first African American to attempt to enter the University of Alabama. It was not successful. She was not enrolled at the University of Alabama. She tried, but there was violence, and she was pulled out of the University of Alabama. The law at the time in Alabama made it illegal for African Americans to go to the University of Alabama, so she did not have a legal right to go there, right? It's clear. She did not have this was in 1959. She did not have a legal right to attend the University of Alabama. But many people, most people perhaps, think that she had a moral right to attend the University of Alabama, even though she didn't have a legal right. Most people think there's a problem when moral rights and legal rights don't match up, right? If you have a moral right to something, but the law makes it illegal, that's a problem. Arthurine Lucy Foster had a moral right to attend the University of Alabama, but she did not have the legal right to do so. And many people think that that's a problem. So human rights are moral rights. They are rights that are not part of the legal system, and they are often used to critique the legal system. So, as Nick just indicated, if someone says that healthcare is a human right, they're trying to say that there should be a legal right to healthcare, right? They are saying there's a problem with our legal system that it does not provide this moral right. Does that make sense? Just as it was a problem with our legal system that it did not provide a legal right for Arthurine Lucy Foster to attend the University of Alabama. But not all moral rights are human rights, because some moral rights are sort of trivial. They're not really very important, okay? So if Elizabeth here promises me a Snickers bar, then I have a moral right to a Snickers bar. But it's not a human right, mostly because it's not that big a deal. Snickers is just not that big a deal. It's just a Snickers bar. And if she doesn't give me the Snickers bar, okay, she's violated one of my moral rights because she promised me a Snickers bar, but who cares? Really, it's just a Snickers bar. I'll go to Wawa and get another one. No big deal. So while I have a moral right, if she promises me a Snickers bar, I have a moral right to a Snickers bar. I don't have a human right. Human rights are moral rights that all humans have to things that are very, very important. I have a right that Elizabeth not torture me. Okay? Sorry, Elizabeth. No. And so that is a human right, okay? Because it is something very, very important, much more important than a Snickers bar, okay? It's something that all human beings have. You don't have a right to a Snickers bar because she didn't promise you a Snickers bar. I'm the only one who has a right to a Snickers bar. But all of you have a right that she not torture you, right? Just because you're human, you have a right that she not torture you. So a human right is a moral right to something that's important that all humans have. Does that make sense? See how that works? Okay. So the question is, when we ask, is healthcare a human right? Do all human beings have a right to something called healthcare? And there's going to be questions, right? Because there's healthcare and there's healthcare. There's levels of healthcare. I mean, do they have a right to, say, penicillin? Or do they have a right to a cutting-edge heart transplant? There's all kinds of different levels of healthcare. So you can have a right to some level of healthcare, but not to another level of healthcare. Right? So, for example, there's those semi-glutes right now, like what's that one called? The one that they have, Ozempic, right? And so some people might say, yeah, you have a moral right to healthcare, but you don't have a right to Ozempic, right? At least not unless you're like you need it for some diabetes reason or something like that. So there's a question of what level of health care you have a right to. Okay. So that's the question. When we're asking, is health care a human right, we're saying, is health care something that the government must legally be obligated to provide to everyone because it is very, very important?
Fabulous. Thank you. That was interesting. Well, thank you, everyone. It's so great to be here today. I'm delighted to share a bit about my background, which is different than our two panelists. I'd like to share a little bit of my background and share how it's shaped my perspective around the ethics of healthcare. So I earned my doctorate in public health from Columbia University, and throughout my career, I've experienced healthcare from very different vantage points. From Indo-Chinese refugee camps in Thailand, to managed care organizations in New York City, to corporate offices at Pfizer Pharmaceuticals, and even to homeless shelters right here in Florida. Each experience deepened my understanding of how ethical practice depends not only on clinical expertise, but on empathy, equity, and cultural awareness. So today I'll reflect on how these experiences have defined my view of what it truly means to ethically care for people, and how these experiences inform the broader question that we're exploring today: can healthcare be considered a human right? And if so, what would that truly require of all of us here today? So after college, I spent 4 exciting years working in Thailand, volunteering in an Indo-Chinese refugee camp for Hmong, Mien, Lahu, Khmer, and Vietnamese populations from around Southeast Asia who had fled to Thailand from their countries because of war and challenges, the Vietnam War, the atrocities of Pol Pot and the Khmer Rouge, various civil wars and human rights abuses throughout Laos and Myanmar. And many of these folks had lived in very remote mountainous regions with little or no access to healthcare, providers, hospitals, really very limited. And some of these populations relied on shaman healers, herbal medicine, or herbal remedies, and traditional birth attendants to manage their care. And my goal in the camp, where I worked in maternal and child health care, was to help to understand what health care and what life in general might be like in the United States, because many of them were preparing to be resettled in the near future. So I introduced concepts of Western medicine, like vaccines and pharmaceuticals and modern medicine and surgical care. And one challenge I particularly remember was trying to describe how these concepts like vaccines, how important they are to these mothers who are going to have children entering into the U.S. public schools. How would I gain their trust so they'd understand how important a vaccine is? So I worked with the village elders, and we came up with a project and a program to earn their trust, which was a real challenge with populations that have deeply held beliefs. Another important story I remember was the rumors that circulated in our camp that American physicians were eating Hmong men. And this was a tragic misunderstanding that arose when doctors had performed autopsies to understand why so many young Hmong men were dying suddenly in their sleep. It was later turned that it was from Brugada syndrome, which is usually caused by a mutation in the sodium channel gene. But this is a stark reminder that medicine can't succeed without trust and cultural understanding. My key learning from this experience is that health is more than medicine. It's about cultural respect, trust, adaptation, and ultimately the ethics of healthcare lies in bridging the gap between scientific knowledge and cultural beliefs, ensuring that care is not only clinically effective, but morally responsive, equitable, and grounded in human dignity. So while living in Thailand for 4 years, I witnessed an unbelievable transformation, one of the world's most remarkable transformations, which back in 2001, Thailand launched its universal health coverage scheme. Within less than 5 years, the country expanded universal health care to, they started off at less than 70% of their population to more than 99% of their population in such a short time. And this system was financed through general taxation rather than employment-based contributions to ensure that their informal workers, those who are often excluded elsewhere, were covered by this insurance scheme. Providers were reimbursed by capitated payments, which is a fixed cost per patient, incentivizing prevention and efficiency over costly interventions. And most important, healthcare was framed as a right of citizenship and not an act of charity. So the results were striking. Out-of-pocket spending and medical impoverishment declined dramatically. Access to primary care, even in the rural provinces, expanded dramatically, and costs were contained through a focus on prevention and community-based care. So what was my key learning from this experience? Thailand was able to demonstrate that universal, ethical, and financially sustainable care is achievable, even in a middle-income country. So, upon returning back to the United States, I completed my doctoral studies, and I entered the world of managed care, where I was confronted with the realities of our extremely fragmented healthcare system. My first role was in quality management for a New York City Medicaid prepaid health service plan, where I saw firsthand the challenges of providing coordinated care to vulnerable, low-income urban populations. I saw providers delivering poor quality care since there was really no incentive for them to improve because reimbursement was so low for Medicaid. And later I worked across commercial and Medicare health plans where I designed innovative disease management programs focused on prevention. I developed data-driven, multi-arm, multifaceted disease management programs involving case management, educational group meetings, individualized counseling, telephonic outreach, and our outcomes were dramatic. My key learning from that experience was that prevention and coordination are not just efficient, they're ethical imperatives. Keeping people healthy is as important as curing illness. And after several years in managed care, I transitioned to the pharmaceutical industry working for Pfizer in managed care strategy. There, I collaborated with health plans to ensure patients could access their medications that they needed to manage their chronic conditions. But this experience offered a really different perspective for me. I witnessed the tension between innovation and access. Pharmaceutical breakthroughs can transform lives, yet they often reach patients when it's too late, only after disease progression, or they remain totally out of patient's hand because they're so costly. So my key learning from this experience was that scientific innovation is extraordinary, but it must be connected with prevention, affordability, and ethics for it to truly serve humanity. And in recent years, my volunteer work has brought me full circle back to the human side of healthcare. Through my work with the St. Augustine Homeless Coalition, I've led healthy cooking classes and exercise programs and art sessions for women and their children. And these experiences have reminded me how important the social determinants of health how important they are and how profoundly they affect health. I've seen the limitations of our social safety nets, from homeless shelters that were filled, the homeless pantries that were filled with donated non-perishable foods, like boxes and boxes of Krispy Kreme donuts and Chips Ahoy cookies, and families whose medical bills have driven them into homelessness. I remember a young mother with 3 young children who lost her home after developing cancer. And this is a devastating example of how illness and poverty reinforce each other. And I've also had the opportunity to work with refugees, helping families navigate the quagmire around housing, education, and Medicaid. And many face barriers that had nothing to do with medicine. They had no access to transportation, low quality or simply no affordable care, limited access to computers or technology. And one woman I worked with had to take 3 buses to reach her doctor, missing an entire day of work, which was unacceptable for her employer. For her, the barrier to health wasn't the hospital, it was simply the bus route. And my key learning from this experience was that healthcare without a focus on the social determinants of health is simply incomplete. Access to quality care, education, safe housing, nutrition, and economic stability are not peripheral to health. They are its ethical foundation. A just healthcare system must recognize that inequalities in these conditions produce inequalities in outcomes, and that the moral duty of healthcare extends beyond the clinic walls to addressing the social, structural, and environmental forces that shape our well-being. In this sense, the ethics of healthcare demand both compassion in treatment and justice in the systems that make health possible. So, in closing, from refugee camps to corporate boardrooms, I've learned that public health is fundamentally about connection, connecting people, systems, and compassion. Across every one of my roles, from quality management to disease management to pharma to volunteer services, one truth has remained constant. The ethical challenge in healthcare is not what we do, but whether we choose to do it for everyone. So I leave you with a question. Is healthcare a human right? If so, what would that truly require of all of us? And if not, who gets left behind, and what can we do to change that? Thank you.
Well, thank you, Dr. Paul. So, one of the classes that I teach here at UNF, or used to teach before I became a full-time administrator, is constitutional law. And so when I hear the question that Dr. Paul posed at the end of her opening remarks there, my mind as a political scientist, it automatically goes to the Bill of Rights, right? It's right there in the name. These are the rights that our founding fathers considered important enough to codify, to write down, and ultimately then it becomes a question of government power. And when I think about rights in terms of public policy and government, and to address the question from the end there, you have to distinguish, I think, between what we might call negative rights, restrictions on government power, and positive rights, an affirmative obligation on government to provide citizens with some kind of service. Now, it's no coincidence that if you go through the Bill of Rights, the first 10 amendments to the Constitution, the vast majority of those are negative rights rather than positive rights. They are restrictions on government power. Government may not interfere or abridge your freedom of speech. Government may not interfere with your freedom of religion. Government may not take your guns away. In fact, almost all, with one exception that I'll talk about in a second, but pretty much all of the rights that are codified in our Constitution are negative rights. And for a good reason, that it's a lot easier to enforce a negative right than it is to enforce a positive right. And maybe the sole example in the Bill of Rights of a positive right will kind of illustrate how challenging this is. So the Sixth Amendment to the Constitution has various protections in it dealing with the rights of the criminally accused when they're put on trial in a criminal setting. And one of the rights that is contained there is the right to counsel, essentially the right to be represented by an attorney at trial and at other stages during the criminal prosecution process. And for most of US history, this was interpreted as a negative right. The government could not interfere with your ability to hire your own attorney, bring that attorney with you to court or to interviews or to questioning, have them access you while you were incarcerated or in pretrial detention, and to have them assist you in your defense. The government could not use its authority over the criminal justice system to take that right away from you. However, during the mid-20th century, the Warren Court, under the leadership of Chief Justice Earl Warren, made a number of transformative decisions. And one of those decisions was to convert the right to counsel from a negative right to a positive right. So now, not only could the government not interfere with your ability to procure your own assistance of counsel, but government is affirmatively required to provide you with an attorney if you are convicted of a crime. And we've all watched Law and Order or some other police procedural, right? When they arrest you, they read you your Miranda rights. One of the first of those is you have the right to an attorney. Should you not be able to afford an attorney will be provided for you. That is a positive right, which means that the federal government in federal criminal prosecutions needs to hire public defenders. It needs to pay those public defenders. It needs to provide those public defenders with the resources to assist their defendants. It needs to provide them with the resources to investigate, to secure experts, to collect evidence that attempts to try and clear you of whatever criminal offense you've been accused of. Every state government, every district attorney's office that prosecutes criminal cases has to have a public defender as well. So at all levels of government, the transformation of this right from a negative to a positive right creates financial obligations for government, creates bureaucracy that has to be built and assembled in order to make that right effective. And speaking of effective, there were a series of other decisions which went further in changing this negative right into a positive right. So not only do you have the right to be represented by an attorney, and not only do you have the right to have the government provide you with an attorney if you cannot afford one, but that attorney has to provide you with effective assistance of counsel. So if the government denies you your own lawyer, your right to counsel has been abridged. If you're poor, you can't afford a lawyer, the government doesn't provide you one, then your right to counsel has been abridged. If the government pays for a lawyer and they're completely incompetent and they sleep through half of your trial, then similarly, your right to counsel has been abridged. So when you go from the world of negative rights to the world of positive rights, it becomes much more difficult from a public policy perspective, much more expensive from a government revenue perspective, and much more complicated from a logistical perspective to make that right effective and consistent. And that's why I think, and with good reason, the framers of our Constitution decided that negative rights were the things that it was important to protect, and the extent to which positive rights are provided by government is decided democratically. It's decided at the ballot box. We vote politicians into office. Those politicians then decide what kind of healthcare coverage we get, what kind of housing assistance we get, the extent to which governments, to go back to Dr. Rainbolt's presentation there, have an obligation to provide these services to citizens. And so I want to ask a question, actually, of Dr. Rainbolt here, because when you convert a negative right into a positive right, you are not just creating an obligation on government not to interfere with you, you're providing an obligation on government to provide an affirmative service to you. In essence, you have competing moral and ethical values. And the provision of such a right can sometimes interfere with other people's rights. For instance, their right to their property. The government is going to have to raise revenue, and to do so, they're going to have to require people to pay taxes. And so I'm curious, Dr. Rainbolt, when it comes to kind of the framework of philosophy and ethics, how do you deal with competing rights, with competing moral and ethical values? And how do we go about kind of weighing those things against each other?
So you're absolutely right that negative rights are much easier to respect than positive rights. It's quite easy for me to not kill all of you. It would be much harder for me to give all of you $150. That would be a lot harder, right? So if you have a right that I not kill you, it's pretty easy for me not. It's a negative right. You have a right that I not kill you, and I'm pretty sure I can do that. It's not till 7:30. I'm pretty sure I can hold off and not kill anybody till 7:30. But if you say I have to provide each of you with $150, ooh boy, I mean, I'm not sure I've got enough at the bank account right now, right? So positive rights are much more difficult to enact, to respect than negative rights. And that's generally why, if you look at lists of human rights, as Dr. Seabrook points out, they are often lists of negative rights. If you look at the UN Declaration of Human Rights, there are a lot of negative rights there. On the other hand, there are often some lists of positive rights in those rights. And so somebody who thinks that health care is a human right is essentially saying, and this goes back to what I talked about before, they're saying this thing is especially important. It's not like that Snickers bar. It's something really, really important. And so it is something that the government must provide. And that means they're not going to be able to do other things. They're not going to be able to build as many roads. They're not going to be able to spend as much money on university education. They're not going to be able to spend as much money on agricultural research, on and on and on and on, all kinds of things the government says. So if you say that something is a human right, you're saying it's something especially important. And therefore, the governments have a moral obligation to provide it, which means that they're not going to be able to provide other things. Moreover, they're saying that this is so important that, in fact, your rights to income are limited by this. We have the right to take money from you to satisfy this human right. So if you say that health care is a human right, you're saying something quite important. You're saying something strong. You're saying that this is something that is more important than say, for example, I don't know, the right to drive on a really nice highway, or the right to have the government provide extension services for helping to grow crops or things like that, right? So you're saying that this thing has got to be it's got to go to the head of the line. It's got to go first. It's got to go in things. So you can't have a lot of human rights. If you have too many human rights, they're going to crowd each other out. It's not going to work. So the number of especially positive human rights is going to have to be pretty small. Does that answer your question?
It does, and thank you for that. I have a question for Dr. Paul as well. So, with your knowledge of healthcare systems, not just the U.S. healthcare system, but as you've talked about, healthcare systems across the world, and the development of healthcare systems that might make a right to healthcare actionable. Let's say that I talked about how the Bill of Rights doesn't contain a positive right to healthcare. But let's say we got together and convinced our fellow citizens that that was a good idea. We got the requisite number of state legislatures to ratify an amendment. We got Congress to pass it by 2/3 majority. And we added a new amendment to the Constitution, which says that every American has a right to healthcare. How might such a right be implemented? How might it be operationalized within the healthcare system that we have right now, and based on the way that other countries have gone about providing this to their citizens?
It's a great question, and I have to say, in my graduate studies, I spent my fellowship was at the CDC analyzing healthcare legislation from the 107th Congress. So trying to figure out which potentially might work for a universal type of healthcare if Hillary Clinton had under her program. And it's definitely challenging. And I think looking at countries like Thailand, there is some hope that a universal type of healthcare system could be implemented. But then if we look at our neighbors like Canada, looking at healthcare, like rationing. And I know with my father, he was very worried that he wouldn't get a certain procedure because he's too old. And, that he said, well, I'm just going to be in pain the rest of my life. So I think there are pluses and minuses that we would have to give up. And if you look at many of our highly developed countries, we spend the most on our health care, and our outcomes are not. We're right on the bottom. There was a Kaiser Family Foundation report from a few months ago that is dismal for U.S. healthcare. We literally spend so much money, and our outcomes are low because of access challenges and other challenges. So there definitely, if we want to go that way, there's so many factors that come into play that as Americans, we want certain things. We want healthcare in a certain way, and it's a totally different mind shift in terms of if we do want to provide healthcare to everyone. And it's that one question I said: if we do want to provide people with healthcare, what do we give up? And how does that affect all of us here?
So I talked a little bit about kind of the difference between something that's a constitutional right that is guaranteed under the U.S. Constitution and, as Dr. Rainbolt talked about, just something that is established by law. So where the government is basically saying, we are committing that we are going to provide this for our citizens. We are not required to do so, but the people who have elected us think that this is a good idea, so we're going to appropriate the funds, we're going to design a system, and we're going to spend money to provide people with health care. And so, interestingly, I think there are different answers to the question of both whether a negative right to health care exists in the United States and whether a positive right to health care exists as well. What might a negative right to health care look like? So just as the First Amendment prohibits government from interfering with your freedom of speech, engaging in prior restraint, punishing you criminally, or in most cases civilly for things that you say, presumably a negative right to healthcare would prevent the government from interfering with your private healthcare decisions. You can go see whatever doctor is covered by your particular plan without restrictions from the government. You could get medical advice, prescriptions from your provider, and the government does not stand in the way of you obtaining those things. But the truth is that here in the United States, we don't have a negative right to healthcare in the Constitution either. We have broad rights, including liberty. But the government does a lot of things that regulate the practice of medicine and regulate the healthcare decisions that we make on a day-to-day basis. The government says that certain drugs cannot be prescribed, even if a physician might be inclined to do so. The government says that certain treatments cannot be recommended, cannot be allowed to happen. We've seen a number of debates recently about state laws that prohibit gender-affirming care for minors. So there are all kinds of ways in which government regulates our access to healthcare in a way that undermines even its viability, I think, as a negative right. But do we have a positive right to healthcare here in the United States? I think in a lot of ways we do, and it's one that has been established through legislation. At the most basic level, there's a piece of legislation called the Emergency Medical Treatment and Active Labor Act, known as EMTALA, which says that any hospital with an emergency department which participates in Medicare, which allows Medicare patients to access it, which is most hospitals in the US, must provide appropriate medical screening to anyone who seeks care, stabilize any patient with an emergency medical condition, regardless of ability to pay, insurance status, or citizenship, and if unable to stabilize, arrange an appropriate transfer to a facility that can. A hospital that violates EMTALA can suffer fines of over $100,000. They can be excluded from Medicare. There are serious consequences. So at the most basic level, healthcare providers are required to provide treatment in the event of an emergency to people who find themselves in those situations. Now, they can refuse to provide non-emergency or routine care, but the federal government also affirmatively obligates providers to, for instance, if they take Medicare patients, they bill the government pays for that. With Medicaid, it's a program that's jointly administered between the states and the federal government, but the idea behind it is the same. If you qualify, you can have your expenses reimbursed. Between all of these different systems, between Medicare, which covers seniors, because between Medicaid that covers low-income individuals, and the enhanced subsidies that are being debated contentiously right now in DC, we have a pretty strong positive right to healthcare that has been established through legislation. Now, it's not a human right, as Dr. Rainbolt was talking about. It's not a constitutional right, but it is a right that we enjoy on a day-to-day basis. But even when you affirmatively require, in this case, government, to provide certain healthcare services to individuals, the ethical problems, the ethical quandaries don't always end there. Because whether you have a system like, for instance, the UK, that has a national health service, a government-run healthcare system, or if you have a system like the US, which is this weird hodgepodge of government programs and private employer-provided insurance, healthcare resources are always going to be scarce. And given that scarcity, how should competing moral and ethical values guide the allocation of these resources? And how can a system of health administration be designed to deal with those trade-offs? So I will put those questions to my two expert colleagues.
Go first, you want to? The question that we're asked here is healthcare a human right? It's a nice simple question. It's good to put on a poster, but it's not complicated enough because there's lots of different kinds of healthcare. You know, there's basic healthcare, you know, just like emergency level stuff, basic vaccinations, basic antibiotics, right? And then on the other end of the spectrum, there's, you know, aesthetic surgery. So that, for example, if I don't think my eyebrows are fluffy enough, I was at a dermatologist and they have eyebrow fluffing hair, and I could get thicker eyebrows if I wanted them. So there's all kinds of different kinds of healthcare. And so when we're talking about human rights, I'll go out on a limb and say nobody has a human right to fluffier eyebrows. Okay, I just don't think that's not important enough. That's like the Snickers bar, right? That's just not important enough. Now, if you want to go buy, I think there probably should be a negative right. If you want to go buy, I'm not sure what it's called. They probably have a better name for it. Do you know what they call when they? I don't know. Anyway, they do the thing where they make your eyebrows like fluffier, thicker. So if sorry, obviously this sort of, I was sitting in the waiting room and I was like, wow, there's a poster for thicker eyebrows. I was like, I didn't know you could do that. Anyway, so I think when we're talking about healthcare, is healthcare a right? We need to be we'd be better of what kind of healthcare is a right, right? So as Dr. Seabrook's pointed out, in the United States, we've decided that you have a positive legal right to emergency healthcare. That's a decision we've made. But of course, human rights, as I emphasized, they're not about what people decide. Either you have a human right, something you don't. And for example, in the case of Arthrine Lucy Foster, she didn't have a legal right. They had a vote, and they voted that African Americans didn't have a right to go to college. So there was no legal right there. But many people, including myself, think that she had a moral and a human right, even though the moral and human right could exist even though people don't vote for it. All right. And so I think the question is, for many people, what level of healthcare do we have a human right to? It could be none, but it could be, you know, more or less. And there's a lot of different ones. And the one you see right now, that's the one I mentioned before, those semi-glute drugs. Right now, they're not covered by very many pharmacy plans, right? But it wouldn't surprise me if they turn out to be very effective, and if they got to be cheaper, that they would be covered. And the case, for example, of heart transplants. You may not know this, this is what comes from being old, but I remember when heart transplants were first able to be done, they were not covered by health insurance. They were very, very expensive, very, very hard to do, and they were not covered by health insurance. But now they are, because the cost has gone down dramatically and they have gotten much better. So the level of care that we can provide is dependent on technology, and it changes over time. All right? So in 1850, nobody had a right to, I can assure you that in 1850, nobody had a right to a heart transplant because there was no way to do it. Right? But right now in the United States, someone might well argue that there is at least a moral right, maybe not a human right, to health care. I'm not sure whether I answered your question or not, because I forgot what your question is.
It was to do with the ethics of allocating those scarce resources.
Well, there's a difference between then the ethics of allocation, as Dr. Paul was pointing out. I mean, if you're just talking about the ethics of the allocation, the United States allocation of healthcare resources looks to be pretty bad from an ethical perspective, because we spend a huge amount of money and we get really bad outcomes. Other places spend a lot less money and they get a lot better outcomes. So this seems to be, if you're just asking about the system, I mean, if I didn't look at the Kaiser one, but 3 or 4 years ago, I looked at one. We were dead last among.
We were dead last.
Yeah, we were dead last. We were dead last in outcomes, and I know for a fact we are number one by a lot in cost. So we have great. We are the most expensive, and we get the least. This is not the right way to allocate healthcare resources, such that you spend the most and get the least. That's not the way to do it. Our system is not a good system. I have some suggestions for improvement, but maybe I'll just pass it on to you.
Because I wanted to add that there's so many issues with access within our country, and that's we have one of the highest infant mortality rates among any country. I mean, it is ridiculous because of all of our access challenges. It is so, especially among African American and Latino women. I mean, it's just crazy. And so we really need to shift a focus. Like I've had experience working in commercial health plans focused on health prevention programs using data mining to figure out who has a hemoglobin A1C, which is a key indicator if you're going to be developing diabetes. You start looking at the data to see who hasn't been determined to have diabetes yet, but who is going to, if they stay in the same path and enter in early with those individuals to keep them from going down and becoming, complicated diabetic patients. So that's focusing the efforts on prevention. But prevention is a lot of money. And the problem with health plans is that health plans don't want to spend a lot of money on their patients because or they call them members. The member will just change health plans next year. Because this one, my doctor moved, so I'm going to go to that one. So they don't want to spend a lot of money on prevention. So that's a huge problem. I was able to work in some plans where they did allow us to focus on prevention and our outcomes were fabulous. But then guess what? Our health plan got eaten up by United Health Plan. So that was over. So, we've got to focus on how to improve our access challenges within our country. And we can look to other models for what they've done. But we're going to have to, it's a give and take. We're like managed care, we use prior auths. You have to get a prior auth before you can have a procedure. You have limited doctor panels. So those would have to come into play more and more.
I'll just piggyback on what you were saying. This is contentious, okay? So I'm about to say something that a lot of people disagree with. But I personally think that perhaps the biggest fundamental problem with the U.S. healthcare system occurred shortly after World War II. What happened shortly after World War II is that they changed the tax code and made it such that if you give somebody, if an employer gives somebody $1, they have to pay taxes. But if they give them health insurance, they don't have to pay taxes. And as a result, if you look around the world at other developed countries, we are the only one that links employment and health insurance. And I have friends that come over from Europe, and they think it's just bizarre that we have a benefits office. They're like, you have a benefits office at a university that works with health care? Why do you do that? You're a university. Why are you dealing with health insurance? Why? This is stupid. Why is the university handing out health insurance? It's a university. They look at it and they're just like, well, what's going on here? But the problem is, and this was not planned, they put this in, this was it was a tax loophole that was put in, as I understand it, by the unions for certain places, but it got to be really popular. And now the problem is that we have a lot of the complications of this is that our health insurance is tied to our employment. Mm-hmm. Which, when you think about it, is a very weird thing. When my friend, I was born in the United States, I was raised here, and so it just seemed natural to me, but my friend had some friends come over from Europe, and they were like, dude, this is just really sort of weird to link your health care to your employment. It seems like a sort of a strange way to do it. I think, you can correct me if I'm wrong, but I believe we are the only country that links your health insurance to your employer, where you get your health care through your employer. I think we are the only country in the world that does it that way. Now, there are a lot of countries, so there could be someone I'm missing. But that has caused, we just go, and then the problem is there's so many, I should shut up. There's so many employers, and then that means that we're going to have so much complexity in the system.
And you miss so many people who aren't in formal programs.
They're not employed.
Smaller companies don't have to offer any health insurance at all if you're under, I think, 50 employees. Right. You don't get anything. So, right. So you miss people in that.
In most countries, you buy health insurance like you buy soap. You don't get it from your employer. You go someplace else and buy soap, right? There's not a soap office that hands out the soap, right, where your employer is, all right? In most other countries, you buy health care the way you buy soap. You get money from your employer, and then you go out and buy whatever soap you want from the soap companies. And that's the way most other countries do their healthcare. They don't link it to the employers. But it's as if we could only buy soap through the university, which would be a really weird system.
So I want to make sure that we have enough time left for student questions. So if you've been sitting on a question, in just a couple minutes, I'm going to invite you to come up to the microphone at the front and ask it. But I want to just close with a message that I want to direct at the students in the room, because I talked at the beginning about the expense of healthcare in American society, both in terms of government spending, taxes, the national debt, but just the sheer volume of our economy that healthcare represents. And your generation is going to have some very, very difficult decisions to make. When you start occupying the positions of power in Congress, in the presidency, in state legislatures, this program is only going to get worse. Who consumes healthcare as a general rule? People who are older. There's something called the 55-55 rule. So Americans 55 and older account for about 55% of total US healthcare spending, even though they make up only 31% of the population. And as you get towards end of life, those things become even more skewed. So after retirement age, 65 and older, 17% of the population, we're talking about 37% of personal healthcare spending. And the average annual spending for adults 85 and older exceeds $36,000, which is 8.5 times higher than the amount that's spent on healthcare for children. Americans are living longer. The elderly population is increasing. Birth rates have been dropping. This is a problem that is only going to continue to get worse. Healthcare is a massive intergenerational transfer of wealth in the United States, from younger, able-bodied working individuals to older, sick individuals. And as time goes on, as the national debt continues to grow, as healthcare continues to become a bigger and bigger part of our society, how to deal with the question of a right to healthcare, who should get it, when, who should pay for it, is going to become probably the central public policy question of this century. So I want to close on that, and I want to give anyone in the audience the opportunity to come up to the microphone here and ask any questions that you might have.
My question is for you, Dr. Seabrook. So I'm rationalizing these 2 points, right? Life, liberty, and the pursuit of happiness, as outlined as inalienable rights foundational to the United States Constitution. It seems rather difficult to give someone the right to life if they're dead because they cannot afford health care, the right to liberty if they cannot move about their life in such a way that allows them freedom because they're dealing with crushing debt, or just the genuine pursuit of happiness if you're sad because you're sick and you cannot afford the health care necessary in order to live a happier and healthier life. And I am not just concerned, but also dealing with this dueling principle of how we're actualizing or manifesting this idea of an inalienable right through those three particular examples, but also denying people the right to health care. It seems like the American political ethos is not necessarily living up to the expectations that was established by the Founding Fathers. And I was hoping you could shed some light on that.
So, as you say, the three key rights there, life, liberty, the pursuit of happiness, kind of foundational to America. But I think ultimately this question comes down to not just should we be free to pursue those things on our own initiative, but the extent to which others should be responsible for providing those things to us. And in the context of healthcare, I think that it's very different to say that there's an affirmative obligation of the rest of society to pay for that versus that you as an individual have the freedom to pursue that. Now, obviously, this is something that a lot of people feel very differently about. And the option is always there. This is why I talked about how the democratic process is the way that positive rights that are not protected under the Constitution can be provided for. And so my response would be that if you and your fellow citizens and if subsequent generations, when they control the levers of power, believe strongly that that is the case, democracy is the mechanism by which you realize that. But ultimately, that's a decision that the people themselves have to make collectively, rather than a decision, I think, that can be enshrined and required of them.
My follow-up to this question. So as a military veteran, I'm afforded healthcare for the rest of my life. This is a socialized program. Actually, everyone in the military, whether you're active duty or a veteran who is qualified for veterans healthcare, relies on a socialist system. And yet, despite the fact that we offer that system, not just to our politicians because their healthcare is also paid for that way, it seems that the only people who aren't offered this idea of healthcare, or at least the structure of socialism that provides for this, is not people within the military or necessarily politicians. It seems like it's the everyday person. And they've been wrapped up in this ethos of individualism that prevents them from seeing effectively the larger picture. I know that I am always closer to being the homeless person on the street than I am to Elon Musk. But I can't see why the average American doesn't believe that taxing billionaires instead of bailing out banks, right? Because we didn't vote to bail out banks, but in the enormity of the American history, we have done this several times when different markets and different institutions have collapsed. So why is it, at least in your understanding, that the average American seems to be more in favor of situations like that, preserving billionaire status, or, for example, bailing out institutions like the banking institutions and when it comes to crises within the housing market, rather than taking care of their fellow citizen?
Well, I think the healthcare component of that really goes back to the point that Dr. Rainbolt made earlier, that we kind of became pigeonholed into this system where the fundamental basis of healthcare in the United States is employer-provided insurance. And everything that we've done since then has kind of been grafted or bolted onto that system to create this kind of Frankenstein monster of a healthcare system. If you were starting from scratch, from first principles, I don't think anyone would design a healthcare system that looks anything like the one that we have in the United States. But there's this idea in social sciences called path dependency, that decisions made at an earlier stage in the development of policy can foreclose certain options further down the road. It would be incredibly difficult in 2025 to go back to the drawing board and put in place an entirely new healthcare system in the US, which is why when we've seen these reforms that have been trying to do what you were talking about there, to make healthcare more available to those who cannot afford it, it's had to kind of work within this existing system. That is the basis of Medicaid. That was the basis of the healthcare subsidies that were put in place under Obamacare, that were extended, although temporarily, in the American Rescue Plan, and that Democrats in Congress are shutting down the government right now to try to protect. So I don't think that this is a system that was designed to do what you're talking about. It was a system that is the product of all kinds of historical contingencies, and it's up to us to do the best we can with what we've inherited from those prior generations.
Thank you.
Dr. Paul, after World War II, basically the tax plan was to give medical care as a benefit to keep employees there. That's why it came into play. And over the years, I've moved from company to company, but I always made sure I had a health plan I was going to. When they looked at the Affordable Care Act, you have to get the money out of the corporations to support the total health plan. Did anyone look at how you can get the money from the companies that they're using for health care for their benefits so it would benefit the greater good of the country? Did anyone do that when you were looking at?
When I was analyzing healthcare legislation?
Yeah.
No, there was no, I don't know how they would ever do that. but nothing that I analyzed. There were so many different proposals during the 107th Congress. It was crazy, I'm not aware of any.
Because you got to get the money out of the corporations to support the greater healthcare plan. And also, it seems like you have to do something with tort reform to change how the lawsuits impact
Exactly.
the lawyers and things.
That's a huge issue.
And if you get rid of that, it comes down to maybe reducing our overall costs. So, any comments from the group on that?
Well, so I started here at UNF as an assistant professor back in 2010, right out of graduate school. And my salary back then was around about $50,000. That same year, the University of North Florida spent $20,000 paying the premiums on the healthcare coverage that it provided me as part of my employment. Now, I was 26 years old. I was not using a whole lot of that healthcare coverage. I would have liked to have had that $20,000. I'm sure that $20,000 could have been put to better use in a whole host of ways. This is just one of the kind of massive inefficiencies in the system that we have now. And it's something that I think has not ever really been confronted in the public policy debates in Washington, whether it's during the Clinton administration, during the Obama administration, or any of the debates that we've had since. But it kind of comes back to this idea that Dr. Rainbolt talked about this truly bizarre system that there has to be kind of a way to break out of this doom loop that we found ourselves in through employer-sponsored healthcare coverage. But not only is it extremely difficult, it doesn't seem to be something that we're even really trying right now.
I think that it's sort of the glass half empty, glass half full. The situation is so bad and so expensive. We're spending so much money and getting so little. And then, as Dr. Seabrook pointed out, it's only getting worse because the percentage of the population that's older is going higher. It may be to the point where we reach a sufficient crisis, but it's going to be very, very hard. Because, for example, suppose you had a system, which is what a lot of other countries have, where the health care is all provided by private individuals, but there's only one insurance company, the government. The government is the insurance company. Everybody has the same insurance policy. That's oversimplified, but there are a lot of countries that do that. People have proposed that, but guess what? The insurance companies lobby very, 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 very hard against that. And they are very good at providing resources to politicians to keep them from voting for something that have the existence. I was talking to a doctor a while ago. This was a long time ago. It's probably got worse then. And he was telling me that they have 136 different insurance forms that they have to fill out because there are 136 different insurance companies they're dealing with. And so he's paying huge amounts of, one reason why our healthcare expense is so high is that we spend an enormous fraction on clerical, on people filing, collecting, billing, blah, 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 blah. We spend an enormous amount of healthcare resources on the clerical side of things, way, way more than anybody else. There are some other problems, but that's one of the big ones. But the optimistic side is that it may get so bad that we possibly can't keep spending 20%, and so it'll blow up, and we'll have to go through and do something. There are other systems, for example, Switzerland, roughly speaking. They have lots of insurance companies, but all their insurance companies are like our public utilities. They are public monopolies. They're not for-profit. They're not for-profit corporations. They're run like the electrical companies. They have to get permission. They're sort of run like electrical companies. So they're semi-private. So they're very heavily controlled. So there are lots of different ways to do it. It's just that the United States seems to have, to be honest, sort of fallen in by this path dependency to literally the worst healthcare system in the developed world.
I had not just about healthcare, but about a lot debates about public goods here in the U.S. And about this government shutdown right now. There's this concept of like the free rider problem, where part of the problem with these ACA tax credits is the idea that illegal immigrants could possibly, that these people who don't deserve it could possibly acquire these benefits. How do you separate your right to public goods that are being provided outside of how much you are providing to the economy? Like, is that fundamental to your right to receive government goods, is how good of a taxpayer you are?
Well, okay, so ensuring that immigrants don't get health care is actually relatively simple from a philosophical perspective. The United States does not have a national ID card. A lot of countries do have a national ID card. They basically have, everybody has to get a passport. About 55% of Americans have a passport already. So basically what, in a lot of other countries, there's this, have you applied for a passport? It's not like you just walk in there and get one, right? I mean, you have to get your birth certificate, blah, 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 blah. Forged passports exist, but they're only for people like Jason Bourne and things like that. They're not for, like, it's really, really hard to get a forged passport. They're just ridiculously hard to get. They're very, very hard to forge. So if anytime you're talking about, well, how could we keep immigrants from getting health care? Well, it'd be relatively easy, not politically, but relatively easy from a sort of practical point of view, which is, well, everybody has to get a passport, and you only can get health care if you've got a U.S. passport. And that would be, compared to the other things that we'd have to do to fix health care system, that would be really easy. Now, the problem is, do you want to do that? Because as Dr. Sieber pointed out, the law actually that we currently have does not say that emergency care has to be provided to all citizens. It says that emergency care has to be provided to all human beings. So it doesn't matter if you show up, and so there's a level of care, a pretty low level of care, that is required by the current law to provide to everybody. And there are reasons for that that might be good. So, for example, especially in some situations, if somebody shows up, and they're like they're like a bloody mess, and you don't know whether they have a passport or not, you don't know whether they're citizens or not, you might want to just say, well, let's just go ahead and treat them because we don't know whether they're citizens or not. So there's certain practical sort of things like, for that. But the short answer to your question is, it would be, of all the problems with the U.S. healthcare system, it's one that's relatively easy to fix. But it would still require Americans to do something that's quite unusual for them, which is to have basically a national ID card, which is to say everybody would have to have a passport. We're already over halfway there. It's not like it's really hard. How many of you have a passport? See, look at that. So it's not that hard to get a passport, right? So if we just said everybody has to get a passport, then it would be because it's virtually impossible. As I say, only Jason Bourne and things like that can get fake passports.
Hi, my name is Chelsea, and I'm a social worker, which means that every one of your professions kind of go into my profession. Now, I'm still learning. I plan on going and get my master's even further than that, hopefully. But I will tell you what I do know. So I work with the disability community here in Jacksonville, specifically spina bifida, which is the world's #1 most permanently disabling condition that you are born with. And as a case manager, I have seen left and right a lot of my families being denied proper health care, specifically in Jacksonville, even though we are considered a medical hub. Many of our families, especially some of our babies, are getting in the car even though their shunt is failing and that their spinal fluids are leaking, driving 2 hours to Orlando to get proper care that they need. And this is a case that is over and over again. So then this question of whether or not that it is a human right to this medical care, we're told life, liberty, and the pursuit of happiness is, given to us as Americans. But then when we talk about this marginalized community, the disability community, something I've worked with for 6-7 years now, that I've just been so heartbroken over the fact that this life, liberty, and pursuit of happiness is not given to this marginalized community, regardless of where they are. We have families coming from Birmingham, Alabama, which is supposed to be the spina bifida capital of the world, now coming to Jacksonville, asking us what we can do. And really, what I can do as a case manager is just point them in the right direction and give them the moral support. But I am not happy with the way that ethically that we are treating this community. And I wanted to know from each one of your guys' perspectives how America can treat the disability community and how we can treat this healthcare system around those who do not have a choice.
I think that's a really important point, actually, and it goes back to what the previous question I mentioned as well. Why don't we condition, why is healthcare not like Social Security, right? So Social Security, you pay payroll taxes over the course of your life, and the more income you've made, the more money that you've paid in, you get more when you retire from the government than someone who has been much lower income and has paid less in payroll taxes? Why doesn't healthcare work the same way? Why do we not condition the amount of care you receive on how much you contribute as a taxpayer? It's because the very same factors that lead to you needing that healthcare treatment and coverage in the first place are factors that are in many ways preventing you from making those contributions, that you're maybe someone with a disability who is unable to work. People don't choose to get older. People don't choose to suffer the inevitable medical issues that come with age as well. So I do think it's very important when considering the question of healthcare as a right that it does recognize that that this is not something that people control, and it's not something that I think should be conditioned on. I don't think that if you're disabled or if you're old that you're free riding because you're getting health care and you're not paying a lot in taxes. And I think that's very different in the context of healthcare than it may be in certain other areas of government policy.
Thank you.
And I'd have to say, I confronted the same thing with the homeless community and the social determinants of health and how incredibly important they are. And like the young mother with 3 young children who developed cancer and was thrown out of her apartment, or the other mother whose boyfriend burned down their apartment building and she still had to pay rent on that and couldn't get into another. There's so many barriers to care.
I see it every single day.
Yeah, it's just unbelievable. It's frustrating to me to see, to look at other countries and see how they help people who, and it's not charity. Like, we see it as charity. It's not charity. It is, we all have a right to health care, I believe.
Thank you.
Thank you for what you're doing, though. That's amazing.
Yeah, can I sit down?
Sure.
Yeah, of course.
Go ahead.
Yeah, so this is for daughter Rainbow, maybe worker, maybe she work you want to it's a but like work with new technology, work with new technology. And with new like innovation and the society. Do you believe like some of those can become a human race? Like how can we what can we collect? For example, like back in the 1700s, let's say like somebody tried to like commit like a suicide by a city to west. But like back then, if you caught the daughter, it maybe would cost like it maybe would cost like $200 for the doctor to like help you do it because but now it's so we do that it will cost a lot more because now we have new technology and new like medical centers so like. Can I so this become like a human race? They don't. Yeah. Do you more itself of it? What is it like? Back to the 1990s. Look like me, like I say, disability. I'm a person. Party, we had the right to like you say like a laptop and tablet because like they were like new back then. But like now, but like now, at UNF, I had to watch, I had to watch to use a laptop in class because of my because of my ACA this another ADA. So like, can this become a human rights?
Yeah.
When new technologies are made?
So I think the answer to your question is yes. It's a very, very good question. It's something people don't often think about, so I congratulate you for thinking about it. People often think of human rights as sort of static, that the human rights are the same for all time. But actually, if you think about it a little bit more, that can't be right. Because, for example, it's no way that I had a human right to an antibiotic in 1750 because there were no antibiotics. So even if there's a human right to something, it has to exist, right? You can't have a human right to something that doesn't exist, right? And so, if we're talking, as I say, you have to different level of standard of care, but suppose we're talking about a simple antibiotic. It seems to be that would be something that what someone might argue at least we have a human right to that right now. And what people forget about medical technology is that it's expensive at first, but it gets really cheap. So for example, antibiotics used to be really, really, really expensive. In the 1950s, antibiotics were ridiculously expensive. And I went to Publix a couple of weeks ago to get some antibiotics, and they were having problems with my insurance. And I said, look, can I just pay for this cash? And she said, oh, but you won't get insurance. And I said, how much is it? She said, $7. Yeah. And I said, okay, fine. Well, look at that. I got to go buy some tomatoes. Here's $7. Give me the antibiotic. I don't want to deal with this. The antibiotic has gotten, and that was the uninsured cost. The antibiotic cost $7. So things that are really expensive, new technology is expensive. But over, unfortunately, sometimes a long period of time, the costs dramatically go down. So the answer to your question is yes. It may be that, for example, some treatment is so expensive right now that it is not a human right. We do not have a human right level of treatment. But in 20 years from now, the cost may have come down so dramatically that it is, in fact, now a human right. So the answer to your question is yes, that our human rights change as technology changes over time.
Do you think there are levels of human rights? No. For example, there is more money education resource. I believe there is more money education resource than into resources into my disability. I will say the casual resource is a lot more important than my disability resource.
Yeah. Once again, you've made a very good point. Philosophers tend to not like the term human rights because it sounds like either you have a human right or you don't have a human right. Mm-hmm. And philosophers tend to prefer to say, how important is your right? And, there's a scale from 1 to 10, and we use the word 10 for the human right. That's the highest, most important things. But that doesn't mean that if it's just a little bit less than a human right, now it's nothing, right? That there's going to be levels of rights. And so, I didn't want to say that in the beginning because you don't want to make things too complicated. But is the question a human right? It says a human right, as if there's either you have a human right or you don't, right? But I would like to say, here's a question that a philosopher would ask. What level of health care is what level of human right? That doesn't sound very interesting. It sounds really boring, actually. But that's the way the philosophers would think about it, that human rights are more or less important and that things can sort of become more or less important over time. So yes, the answer to your question is I think that there are levels of human rights. So, for example, I think that the human right not to be tortured is a very, very high level. It's a higher level than, I would say, than the right to health care.
Yeah, if we're talking about human rights, I do not have a human right to my wheelchair because I can walk. It might take me an hour to go to camp I can walk to like my retail in like how human right, but I feel like it may like a societal right to allow me to have a retail to build move around, let's say the campus of everything. Yeah.
I don't want to monopolize the conversation, so. What? Nick, you're a leader here.
I'm afraid I didn't
Okay.
hear the question very well.
So it was hard to understand your question, but I think that what you were saying, and I may well be getting this wrong, I'm very sorry, but that I think that, there is this kind of ideal that your rights and all our rights may change over time, and as, you have a right to walk, but then there's the other problem is, of course, you can't have a right to something that can't be done. So, as I say, in 1850, you didn't have a right to a heart transplant because there were no heart transplants; they couldn't be done. But over time, it would be hopeful if we could cure spina bifida. I'm not sure. If we could cure these things, then you might have a right to that treatment. You don't have a right to it right now because we don't know how to cure spina bifida, right? But if we learn how to cure it, then at a certain point, you might have a right to the treatment that cures spina bifida over time.
Hi. If you all would indulge me, I did have a couple comments about some of the stuff that was said during the panel itself, and then I do have a question for you, Dr. Reed.
Why don't you have a question for somebody else?
Honestly, I had this question within the first 5 minutes, and it has to do directly with Hobbes, so it's kind of
Okay, you're going to do
thing,
Hobbes.
right?
Cool.
I just wanted to talk about the popularity of universal healthcare. It was mentioned during the panel that we have to convince people that it's a good thing. Based on all of the recent polls and surveys that I've seen, we already have a majority of that. It seems to be more of an issue with the people writing and passing or not the policy, rather than the American people. I mean, you can look at representative U.S. studies showing that we have almost no effect on policy, whether it's passed or not, and that most of the time they listen to rich people and not us. But I digress. Also, somebody also brought up the constitutional right. I found it was interesting that we focused on liberty but not life so much, when in order to have a life, you have to have access to health care. You won't have it for very long. And I also wanted to touch on EMTALA. So I didn't have health care from the time that I was 17 until about 18 months ago. And one of the unfortunate, interesting things about that law is it does not include dental care. No ER in the country that I've been to anyway covers dental care, and dentists are under no similar obligation to treat you. So it was cool for that to be brought up as an example of healthcare being a positive right, but in practice it's lacking. Now my question for you is, so we've been going over Locke and Hobbes in more than one of my philosophy classes as of late, and they talk a lot about the state of nature versus the state of politicized or civilized society, which we supposedly live in, right? I guess my question is, the state of nature, the reason that we go from the state of nature to civilized society is to protect ourselves both from everyone else and to get the things that we need to survive, right? If we are not able to get, I guess my point is, they call those rights that you get, the rights that you have under the state of nature, where if you need something, you could just go take it. And the reason that we don't do that is because we now all live under these agreed upon rules so that we don't have things taken from each other, right? I guess my question is, if we didn't have the right, wouldn't healthcare be one of those rights in the state of nature? I guess is my question.
Right. So, so this is super philosophy at this point. So I don't want to go too far down the road. The short answer to your question is, that the classical discussions of state of nature that you find in Locke and Hobbes, Pufendorf, Grotius, people like that, they didn't really think about healthcare at all. And the reason they didn't think about healthcare at all was because in their time period, healthcare was worse than useless.
Yeah,
That you were pretty much better off avoiding the doctor. The doctors usually caused a reduction in life expectancy. So the short answer question is that the notion of what a state of nature theorist would say about healthcare is very hard to determine, because they were living in a time period when the healthcare was just not really, we'd call it health uncare, right? It was not healthy to be near a doctor. So we're going to get really complicated about questions of what they would have said. I'll just tell you, and Dr. Matheson's not here, so I can say that. Don't tell on me, anybody. I don't find it very profitable to ask questions like, what would Hobbes have thought of healthcare? It's like, would Aristotle have preferred an Android or an Apple? I don't know what he would think. And so I don't think it's really profitable. I don't want to go down the road of saying, would Hobbes or Locke say that that in the state of nature there was a right to healthcare? The answer to your question is they didn't have any thought about it whatsoever, because at the time that they were theorizing, there really wasn't what we call healthcare. I mean, doctors were just a disaster, right? I mean, it was like an astrologer or something like that. It was just horrible.
Sure. I guess I was equating it to like the right to life that they talk about.
Yeah, but they're different people. I mean, Hobbes definitely thinks the right to life is purely negative, right? The right to life is the right not to be killed, and that's all it is, nothing more. And that's definitely what Hobbes thinks. He thinks the right to life is the right not to be killed, and nothing more than that. Even after the state of nature, by the way, even we're in civil society. But now we're getting really into the weeds. I think, I hate to say this, but I think we should probably move along, because we don't want to have a discussion of the state of nature and Locke and Hobbes, because it's, to be honest, except for you and me, I mean, I think it's totally cool, but other people think it's really boring, and I'm aware of that. People tell me that all the time.
I do have one follow-up that might be a little more interesting.
All right.
Does anyone else think that it is a bit ironic that we have a healthcare discussion sponsored by an insurance company?
No, that's good.
Hi, my name is Xavier. I'm a freshman behavioral neuroscience student here at UNF. And I've heard a lot of people talk since coming up here in the Q&A about the rights set by our forefathers to life, liberty, and the pursuit of happiness. And you talked earlier about how implementing healthcare, free healthcare for everyone, there would be trade-offs, of course. And so why do you think it is that people put our right to liberty in getting public defenders to protect your right to liberty over our right to life with free medical care?
That's a good question.
Yeah. Well, so life, liberty, pursuit of happiness are important founding principles, but they are not legal rights. Yeah, and that's how I would think about these things as a political scientist. They're from the Declaration of Independence. They're not from the Bill of Rights or the Constitution of the United States. So I think that's important. That's important to know. I also think, and I will answer your question, but since public opinion came up, I would caution people about reading public opinion polls at face value. If you believe polls, Americans want a dramatically larger federal government, and they want to pay significantly less in taxes to fund it. I'd like to be 20 years younger, and if you asked me in a poll, I would say that, but that doesn't mean it's possible. People say that they are in favor of universal health care, and then you ask a follow-up question. If your taxes went up by a small amount in order to pay for it, that support collapses. So I think that's important to note. So your question was about why there's the focus on liberty rather than life?
Yeah.
Well, I think the most important and most salient point there is that the right to liberty is provided in the Constitution, not just once, but twice. The Due Process Clause in the Fifth Amendment and the Due Process Clause in the 14th Amendment. The right to life is in there as well. But for both of those protections, the government can take those things away if it follows due legal process, if it does so based on fair and impartial procedures. So the right to life is an important principle in the Declaration of Independence, but it's only protected in the Constitution as part of due process rather than something that is absolute.
Yeah, thank you. Oh, you want to go?
Okay. Hello, I'm Matthew. I'm a first-year biomed major, and my question is kind of for both Dr. Paul and Dr. Seabrook. I originally grew up in the Sacramento area of California, so I understand the socioeconomic things surrounding healthcare because there was an abundance of healthcare, but also an abundance of lower-income individuals. But since it was a more urban area, there was still a big gap in between those two things. And when I moved to Florida, I moved to a more rural community where there was lack of healthcare, but also a significant population of lower income individuals. So how, in implementing universal healthcare, do you bridge the gap in rural communities who don't have access to like well-rounded healthcare, period, and lower income areas such as in California where there is healthcare, but it's just so expensive, it's impossible to really achieve for the common individual.
I think for universal health care, we have to focus more on primary care, and we're just going to have more, training more, incentivizing more medical schools to focus on primary care versus specialty. That's a huge thing. And trying to open up more clinics in the rural areas. Like in Thailand, they did it. It was incredibly successful. Very different country, I understand. But that would have to be the push, is to push primary care. And in terms of costs, if it's universal health care, hopefully we'll have, focused on the cost component as well.
Yeah, that's my question. Thank you.
Okay, and we're running low on time, so I'm afraid this will have to be our last question, but go ahead.
So I wanted to kind of circle back to the thing y'all were talking about how access to healthcare or access to other sorts of social services from a rights-based perspective are contingent on their availability. And so I wanted to look at that from sort of a hypothetical lens around post-scarcity economics. What rights-based, things do we need to do around healthcare in a system where we don't have limited access to it in the same way we would in a capitalist system? And how do artificial restrictions on access to healthcare play into this idea that our fundamental rights to healthcare are based on the access we're granted?
I mean, I think you're always going to have scarcity. I mean, you talked about a post-scarcity society when it comes to healthcare. I have a hard time even imagining what that would be, and certainly I don't think there's any political or economic system currently in existence where healthcare is not a scarce resource that has to be allocated somehow. Now, it can be allocated by government, as it is, for instance, in the UK. The government decides through public policy what treatments will be covered, what won't. And things like that, or it can be allocated in a way that is more capitalist or in a more mixed economic system. But it sounds like something of a utopia. Now, maybe there are kind of economics and philosophy concepts here that I'm not understanding, but that's kind of my reaction to that.
Well, if we look at the general idea of scarcity, and we see that in America we have more healthcare scarcity than you would in, say, other similarly wealthy first world countries, and you look at places like Thailand or Cuba that, on top of being able to support their own healthcare systems, are able to, while maintaining a closure in their federal debt, still developing their healthcare systems. And if you look at countries like Cuba, even sending out doctors to other countries because there is an excess. While healthcare as a non-scarcity product isn't commonplace now, we do see it in other portions of the economy. We see that in things like food production, especially for crops like corn. And the framework around how we distribute corn is different, especially from a policy perspective, than how we would distribute some other commodity that does have scarcity in the traditional classical way.
I guess I just fundamentally disagree with the premise of your question. I think there are just different kinds of scarcity. So one country may have a scarcity of physicians, another country may have an abundance. But there are treatments that, for instance, the National Health Service in the UK absolutely will not pay for. And you cannot get those treatments in the UK, but people will put GoFundMes up on the internet and raise hundreds of thousands of dollars so they can come to the US and purchase those treatments from our less socialized medical system. So I think you just have different kinds of scarcity. And ultimately, the question about healthcare policy is a choice of what kind of scarcity do we want to have and how do we want to deal with the ethical questions of allocating those scarce resources. All right. Well, thank you everyone for coming.
Thank you.
Thank you to my co-panelists, Dr. Paul and Dr. Rainbolt, and please check out our other Ethics Week events. We have them going on all week, and you can find them on the Ethics Center website. Thank you.